Welcome to the ASCRS Residence Committee Boot Camp series. This video will provide an overview of the robotic platform with information on robotic buttons and clutches, the robotic console and instruments, and port principle and patient positioning. A key component of the robotic surgical system is the patient cart. Patient cart includes the boom and the 4 universal arms depicted on this image. It also includes the helm, which is located on the opposite side of the cart. The patient cart helm is used for positioning the patient cart. The cart is driven to the patient and then positioned appropriately using the touchpad and boom joysticks. At the superior aspect of the patient cart, you will find the boom and the flex joints of the universal arms. The boom is an adjustable support system that positions the robot over the patient using laser line guidance. The arms are individually positioned appropriately to avoid collisions. Maneuvering of the arms using the flex joints can also allow extended peripheral views of the operative field. While the patient cart helm provides assistant controls for rotation of the boom, there are also boom rotation buttons located on arms 1 and 4 to allow up to 360-degree rotation of the system. As mentioned previously, there are 4 universal arms on the robotic patient cart. Each arm has the ability to be uniquely maneuvered to allow tailored positioning for your operation using clutches and buttons located on each arm. These include the instrument clutch, the port clutch, the patient clearance joints, and the boom rotation buttons. The port clutch is used to dock the robotic arm to the trocar. It also allows movement of the arm, releases tension at the port site, and can also raise and lower the boom with extended port clutch. This last function can also be performed at the patient cart helm. The instrument clutch allows adjustment of the robotic arm without movement of the trocar and assists with positioning of the instruments. Finally, the patient clearance joints. These are used to increase clearance between the arm and the patient, as well as clearance between each arm as needed throughout the operation without affecting the position of the instruments.
The operating surgeon sits at the surgeon console to control the robot during the operation. The surgeon rests their head in the viewfinder in the middle of the console, which provides the surgeon with a binocular view. Within the headrest, there is a microphone and a speaker, which are connected to the patient cart to allow for easier communication with the rest of the surgical team. On the left side of the armrest, these buttons allow for ergonomic adjustment of the surgeon console, including the height and angle of the viewfinder, the height of the armrest, and the distance of the foot pedals. These ergonomic settings can be changed at any time to optimize comfort, and a surgeon-specific setting for these items can be saved in each surgeon's profile so that it returns to that position automatically when logged in. There are 2 hand controls which control the robotic instruments and camera. The surgeon places a thumb and a finger within the grips, similar to gripping a surgical instrument during an open procedure. Movement of the instruments inside the patient mirrors the movement of these grips. For example, opening and closing your fingertips opens or closes the instrument jaws, and rotating or articulating the finger grips will rotate or articulate the instrument head. In addition, there is a finger clutch, which when depressed, disengages the hand controls from the robotic instruments to allow the hand controls to be repositioned to optimize reach or movement of the instruments, while maintaining optimal ergonomics. The foot pedals control energy and other advanced instrument features, as well as toggling between instruments and control of the camera. The blue and yellow pedals are controlled by the right foot and activate the electrocautery attached to the instruments. These pedals can also control the seal and cut functions of the vessel sealer, as well as the clamp and fire functions of the stapler. The black pedals are controlled by the left foot. The far pedal with the crosshairs is the instrument clutch, similar to the finger clutch on the hand controls, to temporarily disengage control of the instruments to allow for independent movement of the hand controls. The camera pedal similarly disengages the hand controls from the instruments to instead allow the hand controls to move the camera. The side pedal, marked with an S-shaped arrow, toggles control back and forth with the third instrument. The touchscreen is located at the center of the armrest and allows you to modify various settings, including the image characteristics such as brightness or image zoom, Tile Pro, Firefly, as well as the movement speed or scaling of the hand controls. Similarly, a surgeon-specific setting for these items can be saved in each surgeon's profile. During the operation, the touchscreen also allows you to see which instruments are currently in use and modify some of the instrument settings. For example, when an angled camera is in use, the touchscreen can change the angle to up or down, or activate Firefly. For instruments with associated energy, the touchscreen can also modify these energy settings. There are a variety of instruments available for use, and the instrument selection depends on the particular procedure and surgeon preference. Here are some examples of some commonly used instruments. The tip-up grasper can often be used in the third arm for static retraction. The bipolar grasper is a grasper with bipolar energy that can often be used in the non-dominant hand for grasping and retraction with the use of bipolar energy as needed. The needle driver is used for suturing, which comes in a large or a mega size, as well as the option for suture cut, which contains a scissor in its base. The cautery hook can be used for fine dissection, as can the monopolar scissors, which can be attached to monopolar cautery. A variety of staplers is available, and they all require a 12mm port. They are available in 30, 45, or 60mm lengths, and various staple heights are available depending on the tissue type. The vessel sealer extend has a squared, blunt tip which can be used for blunt dissection and can divide vessels up to 7mm in diameter. Clip appliers are also available per surgeon preference or for larger vessels, and are available in small, medium, or large sizes, which all fit through the 8mm trocar.
Port principle and positioning. We will start with patient positioning. Patients should be placed in supine or modified lithotomy position depending to the operation. Have the patient firmly secured to the operating room table. Tuck the arms and protect the face with foam or face shield. Padding to the upper extremity should be performed to avoid any injury. Port placement philosophy. There is no single universally correct port placement for any operation. Anatomy varies between patient. The goal of each operation varies and clearly needs to be individualized. The port placement schemata that will be described share the commonality of ports being placed on straight line, oriented perpendicular to the targeted region. The XI arms work best in a parallel setup, which can be achieved by arranging the ports in the straight line. Remember to insufflate before measuring. Setting the ports up straight will maximize the workplace, as stated. Identify the surgical workplace and target anatomy. Place ports in line perpendicular to endoscope target anatomy. 2 instrument ports on one side of endoscope and 1 instrument port on the other side of endoscope port. Accessory ports should be 7 cm from other ports, and do not place the accessory port between target anatomy and the Da Vinci port. The remote center cannula indicated with a thick black band. It is the pivot point around which Da Vinci system moves the arm. Correct placement of the cannula is only thin line at the distal cannula tip, which should be visible. Docking and deploying. Ensure that your bedside assistant is well trained. They will need to actively manage the patient clearance joint and flex joint during the case. Match the current procedure on the console setup. Press and hold, deploy for docking. The boom simultaneously raises pivots, extends and rotates during deployment. The crosshair are positioned within 5 cm of initial endoscope port. The initial endoscope can be docked. Docking. Install the endoscope onto the arm. Use instrument clutch button. Gradually insert the endoscope to point at target anatomy, as shown in the picture. Rest of the arms can be docked and positioned. Adjust patient clearance joint, leaving fist width space between the arms and the patient. Flex joints that all arms are working in parallel toward the target anatomy. Use patient clearance joint to move back end of the arms away from each other if collision occurs intraoperatively. Flexing an arm toward an adjacent arm minimizes interference at the instrument end. To access the area in line with the ports, the arm should be flexed toward the surgical area being worked on. Patient clearance joints move back of the arms away from each other to avoid collision and extra space from patient clearance joint. For right colectomy, place the patient in a slight trendelumbar position and roll the patient to the left side. System deployment is located in the lower abdominal region coming from patient right side. The target place should be the center of surgical work volume that is accessing during the procedure. For example, if the tumor is in the cecal area to be excised, the surgical work volume would reach from right lower quadrant cecal area to hepatic flexure. The center of the surgical volume would be approximately the area of ascending colon, and that should be selected as target side, as can be appreciated on the right side picture. This video will demonstrate port placement for right colectomy. Access is obtained through left upper quadrant. Pneumoperitoneum is achieved. Next step is to measure the distance for the robotic ports. After placing marker for the port placement, we'll start placing our 8 mm port through each of the located area. We then exchange the 8 mm port to a 12 mm port to allow the usage of stapler device in the area. Then we'll place the assist port that is 7 cm away outside from the Da Vinci ports. We now will start the process of docking the robot. The laser will guide us to place the robot at the camera side port. Thereafter, we will install the endoscope to the robotic arm. The instrument clutch button gradually inserts the endoscope to the point, and we will target the anatomy, which will be the ascending colon in the case of right colectomy. After targeting has been achieved, we will insert the rest of the ports to the robotic arms. We will adjust the patient clearance joint, leaving a fist width space between the arms and the patient. Flex joints, all the arms are working in parallel toward the target anatomy, and use the patient clearance joint to move back end of the arms away from each other to avoid collision. For low anterior resection, We position the patient 20 to 22 degrees Trendelenburg and 10 to 15 degrees to the right side. The system deployment would be lower abdomen from the patient left versus right, depending to the operating room. The central target place, as mentioned, will be middle of the surgical space, which is sigmoid colon. We adjust our clearance joint and flex as described. Here's the lesion in the rectum. We place our ports from right lower quadrant to left upper quadrant, camera being the blue port, straight line, assist port outside of the Da Vinci ports, and we target between the two area of work placed.
Thank you for viewing this ASCRS bootcamp video providing an overview of the robot.